Hello, welcome all. Today, we would be discussing further in the Rota Academy. I would be discussing today how to do a rotablation when we are doing a bifurcation PCI. So many times, it's a problem that once we are wiring this both branches, and if we keep a wire into the one rota wire and other the normal wire, then once we will do the rotablation, then this rota bar can cut the other wire. So that is a problem. So here I would be discussing a case of rotablation assisted mini crash bifurcation PCI in a alveolar dysfunction. So this is the clinical history. 45-year-old female, hypertensive, non-diabetic, stable angina for 6 months. She had a low ejection fraction around 38%, and she had a left dominant circulation. So this is how the angiogram looks like. We can see there is a calcified LAD-D1 significant disease with some 50 to 70% disease at the ostia of the circumflex. So the plan syntax score was 16 and the patient was not willing for surgery. So the patient was taken for FFR guided this detection of physiology significance of LCX lesion, and we could see once we did the FFR, it was found to be zero point 0.9. So decision was to do the IVAS of the LAD and then plan for the strategy. And the IVAS revealed a arc of 270-degree calcium. We can see that. So the planning was that this first to this modify this calcified plaque, and this after this the LED was wired with the help of microcatheter. The fielder FC was taken, and once the microcatheter crossed the lesion, then the rota wire was exchanged. So in the figure 2, we can see the rota wire is well placed into the distal part of the LED. And after that, this burring was done of the LED calcified lesion with the help of 1.25 millimeter burr at 160,000 speed. And it was at the end, a good polishing run was taken, and we could see that the lesion looks to be ablated well. And now, after taking out the rotawire again over the microcatheter, fielder FC wire was put into the LED, and now we wired the diagonal again with the fielder FC wire. And the predilatation of both LED and diagonal lesions were done. After that, as usual, what we do in the mini crush, 2.5 into 20 test was deployed in D1, keeping the 2.75 into 24 tests parked in LED. And after this stenting of the diagonal, the wire and balloon from the D1 were removed, and the test in the LED was deployed, crushing the 1 to 2 studs of the 1 to 2 millimeter of the this diagonal stent. Now, after that, the pot, as usual, was done with 3.5 into 10 millimeter NC. And after that, this diagonal was rewired, and ostia of the diagonal was dilated with 1.5 into 10 millimeter balloon. And after that, this FKBI, final kissing balloon inflation, was done with 2.758 NC in LED and 2.510 NC at in the D1 at around 12 atmosphere. And after that, this was the final result. So the take home from this case is that once you are planning for the bifurcation stenting, which will need this dedicated to stent strategy, then of course, first we should try to debulk the to modify the calcium in the main vessel. And for that, we have to be very sure with that no other wire is present in guide at that time, because once you have ablated or modified the calcified plaque, then only we should try to wire the this side branch. Some operators have used the use of microcatheter, putting the other wire in the protection of the microcatheter and doing the rotablation of the main branch. But many times it can lead to the damage of the microcatheter braiding as well. So it's not that easy. It's more difficult than said, because it can cut off the wire. So many times, even with the single wire keeping into the main lumen, we can this modify the calcified plaque, and then we can rewire the side branch. So thank you all for patient listening. In next session, I would be coming up with the more complex rotablation assisted cases. Thank you.